Good afternoon, good evening. Thank you so much for joining us for the Africa CDC briefings on Mpox and Marburg. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by His Excellency Dr. Jean Kaseya, the Director General of Africa CDC, and we are also joined by the head of the Incident Management Team, Dr. Ngashi Ngongo. I will now hand it over to the DG to start the session. Over to you, DG.
Okay, as you can see, next slide, please. What is the new update for the week? You will see in red what we say about Rwanda. After almost 4 weeks without cases, now Rwanda confirmed 20 new cases. We'll discuss that. And the IMST will provide more information on these 20 new cases. The good news, and we need to maintain the trend, we have four countries that didn't report cases for the past 6 weeks. Cameroon, Gabon, Guinea, and South Africa. But we saw in the past countries like Congo Brazza didn't report cases for a number of weeks, but after that they reported cases. And we need to strengthen our surveillance because we know this cross-border transmission of Mpox. In fact, as you can see, we have in Central African Republic, a new district that is bordering Chad now affected. And we consider Chad as a high-risk country due to that. And we still have a number of our countries, almost 14 countries with active transmission of Mpox, in addition to Uganda, where we are recording increase of cases on weekly basis. Next slide, please. In total, we have from week 1 to that current week 43, we have 50,840 cases and 1,083 deaths. What is the most important for us, because this is what is coming mostly when we have questions, how can we say we are at a normal situation? But you will see we have an increase of 545% if we compare the week 1 to 43 with the entire 2023. We are still in this acute phase of outbreak. Next slide. Just for you to have an idea what we are talking about. When in April we organized the meeting in DRC to alert the world about Mpox, we had only 6 countries and around 300 deaths. Then, when we declared the public health emergency of continental security, at that moment, we got 13 countries with 23,000 cases and almost the double of deaths comparing to April. But see where we are today. Number of cases doubled from August to today. Number of deaths almost 70% more, because we have now 1,083 deaths. And we have 19 countries affected. If they can say we are decreasing in terms of cases or in terms of the magnitude of the outbreak, I think this is the evidence that we are still in that phase, acute phase of the outbreak, that is pushing us to double our effort to control Mpox in Africa. Next slide. Just to summarize from last week to the week 43, we had 2,532 new cases. I think if you see the trend, it's almost between 2,500 to 3,000 new cases every week. If we start to decrease this number of new cases, then we can start to talk about how Africa can be out of that. But unfortunately, we are also losing a number of people. Like that week, we had 32 new deaths. I will talk about children in the next slide when we are talking about the epidemic. Next slide, please. We are talking about the demographics in Africa. You'll see that children are still paying a major tribute for this outbreak. If you compare in some countries like Liberia, children under 15, they constitute around 67% of all cases, 50% in CAR, 48% in Burundi. If we can say the average is around 38%, it's mostly due to the fact that in DRC we have so many cases, and what was reported, the children under 15 constitute around 35.8%. But it's still huge for us because we have some regions in DRC where we have more than 65% of children affected. And we also see a kind of shift in terms of gender. Sometimes we have more female, and we have, like when we aggregate data for now, we have more male, 53%. But when you are talking about 53% and 47%, it's still at the same level. It means male are mostly impacted at the same level as female. And we know the comorbidity is playing a key role. We saw deaths that we have in Uganda recently, in Kenya, and also the 2 deaths we had in South Africa are linked to HIV. This is why we are promoting this double testing, Mpox, HIV. And we saw in countries like Burundi, people were coming with Mpox. When they are tested, we are seeing what we call we have new cases of HIV. And we will continue because that one is giving us more information about how even young people are infected, and it's leading for us to change the message we are providing to our communities. Next slide. One of the tools to stop this outbreak is vaccination. We are so glad to see that we started vaccination in Africa, in Rwanda, in DRC. And we know a number of countries already provided a vaccination plan. We are working with others where cases were reported. And as you will see in the next slide, we are planning to send vaccines to a number of countries. For DRC, yes, this is the slide. You'll see out of the 899,000 doses that we have for now, we have a clear plan how to distribute, and this is what we are providing. We hope that with these vaccines, we can continue to support countries to stop the outbreak. But what is the issue? The issue is, next slide, please. Next slide. The issue is mostly we don't have vaccines for children. You'll see as next priorities, because we got from the WHO SAGE, the Strategic Advisory Group, we got a recommendation that the Bavarian vaccine can be used for 12 plus. Now we are working with DRC if they can approve for this vaccine to be given for 12 to 17. And will remain with 0 to 11. And as you know, you saw that children are affected. We are still working with Japan for the deployment of the 3 million doses. I hope with this 3 million, and because the vaccine is well accepted, based on the target that we achieved, we hope that it will make a huge difference in terms of control of the outbreak. Next slide. We wanted to share with you on more transparent way what we got as a result from the DRC campaign. And you'll see frontline workers, it means health workers and other categories working at the hospital. You'll see how they are coming to get vaccine. This is the most important message for us, because health workers are those who are influencing the population to get vaccine. We saw that in some countries during COVID time, where there was resistance, it was coming mostly from health workers. With that slide, we can say they are accepting vaccine. Other categories, we are working strongly to see how we can continue to get them. Even you will see more contact were vaccinated. Yes, we are still working for men having sex with men. And this is a category, even with transgender, we need to continue to do our best to reach all of them, mostly linked to the clade 1B and 1A in Kinshasa. Next slide, please. I will talk about funding, because we cannot continue to respond to this outbreak without funding. We were so excited, all of us, not only partners responding to this outbreak, but the world. During the UN General Assembly, all of us were excited to say we got pledges, and that one will be translated into concrete disbursement. But to date, these pledges are not translated into money in bank account of partners and countries. We want to congratulate Pandemic Fund working quickly to see how the 129 million can be disbursed in a few days to accelerate the response. We have to work closely with the US government. We know the outcome of the election. We are making it clear as Africa CDC, we are working with the US authorities, irrespective of if they are Democrat or Republicans. And for us, the US government committed $500 million to Africa for this response. We want to continue to engage them to accelerate, to disburse this money, and to make the response flying. We don't want to be accused in Africa as delaying the response while our partners, they are not providing sufficient support for the response. Next slide. Before talking about Marburg and Rwanda, I will summarize by saying, as you saw, we are still experiencing the increase in terms of cases in more countries in Africa. You saw the map that today we have 19 countries. And we say we need strong financial support because the political support we have it from African countries. We need strong financial support to intensify the response in all pillars of the continental response plan. We hope journalists who are attending today will help us to make our voice heard, to call upon our partners, those who pledged and those who are still thinking to pledge, to accelerate, because if we don't do that, the world is exposed, not only Africa. The world is exposed. We don't forget that Mpox can become a pandemic if we don't manage it very well. With that, I will give a few updates about Marburg in Rwanda. Next slide, please. As we said, I think since we declared Marburg a public health emergency in Rwanda, I visited the country 3 times. We have a strong team, Africa CDC, but also other partners, WHO, US CDC, European CDC, and so many other partners supporting the country. We appreciate the leadership of the government of Rwanda on the way they are managing that. We are clear that Rwanda is applying transparency, and this transparency is saving lives of so many people in Africa. For the past 7 days, we didn't have a new case. This is good news, and we hope to continue like that. Next week, if we don't have new cases to be the 14 days and the minister will be with us, then we'll start to talk about additional mechanisms that we have to put in place to support that success. We have 2 cases, active cases, still in isolation. And what is the most important one, with all effort that Rwanda is doing, we have 49 people who are recovered, and the case fatality rate that remains the lowest one for all outbreaks that we had, all Marburg outbreaks that we had in Africa. It means to date, we can say Rwanda is moving towards end of this outbreak if we continue like that. But Rwanda is clearly saying they have the response plan of $145 million. The government provided a lot of money, but we are still waiting to see how partners can come strongly to support what the government is already doing. For now, we have a huge gap of around $100 million, and we need to see how we can continue to support. I was in Brussels yesterday talking with European Union Commission to sensitize them to contribute more on the response for Rwanda, while they've also to consider to provide additional support for Mpox. The last slide today is about what Rwanda has in place. It means the dashboard. This dashboard is public. You have the reference. As we did the dashboard for Mpox that was shared with you, Rwanda also did the dashboard for Marburg. We can find on daily basis information that we are looking for. And this is also the way to make the response more transparent. I will stop there and give you colleagues, members from the media, opportunity to ask your questions, and I will be supported by the IMST team to respond to your questions. Over to you, Margaret.
Thank you, DG. Let's take the first two questions from the chat group. The first question asks, how prepared are the other member states to prevent this outbreak? The other question is to Dr. Kaseya. Thank you for the good clarification and updates. How does Africa CDC evaluate regarding the affected member states' political commitment to respond against Mpox? Over to you, DG.
Yes. How prepared are other member states to prevent this outbreak? If you see the continental response plan, we have two components. We have countries affected and countries at risk. And the way we are working and communicating with countries, for those who are affected, we are bringing the response as you saw. For countries at risk, we requested them to prepare a plan. It means to be ready if, unfortunately, they could be affected, but we wanted them to have a plan. Second, we are supporting them to strengthen the surveillance mechanism by providing training, by providing also the lab capacity. And we are also supporting them to reinforce their communication to ensure that the community knows about Mpox. And we are revising this list of affected and at-risk countries because every day, you know, the outbreak is teaching us so many lessons. Now, about how can we evaluate, how do Africa CDC evaluate regarding the affected member countries' political commitment? The first one is how African countries, they accept to apply transparency. You know, everything starts by declaring cases. And if there is no political commitment, the country will not declare these cases. What we got from all African leaders, if there is a case, they will declare that. And they will notify Africa CDC, WHO, and all partners, then we can move on. The second one is about financial contribution. Let me tell you, all countries affected by Mpox, they are providing funding for the response. They are not just waiting for external funds. You know, I was in Burundi. The government said, we have a plan of 8 million. We start with 1 million coming from our own resources. In DRC, when they had a plan of 47 million, they started with 10 million coming from the national government. In Côte d'Ivoire, it was the same case, they started with 2 million. In all countries, I can give you a amount of money coming from the government. The third one is about how to organize a coordination mechanism with all partners to work on a more transparent way on the response that the country must provide. We believe that when all of that criteria are together, we can say there is a strong political commitment. Now it's up to our partners to come to support this political commitment, knowing the challenges that our countries are facing. Over to you, Margaret.
Thank you, DG. Let's cross over to the floor. Sarah Javin from DVEX, you have the floor.
for the presentation. You had briefly mentioned the U.S. election in regards to the Mpox pledge. I'm wondering more broadly if you could elaborate further. What's your reaction to the U.S. election results and how it could impact global health efforts and support for Africa CDC and outbreak response in Africa in the coming years? Thank you.
Thank you. Let's take the next one before DG comes in. Dorcas from BBC, you have the floor.
I have two questions for the DG. Why has Burundi not received an allocation of Mpox vaccine doses, yet it has the highest disease burden after the DRC? And we know the experience that was with Burundi with COVID-19 when they vaccinated late. Could that also be the case? And then what accounts for Rwanda reporting 20 cases after 4 weeks of not reporting any? Is there any link to the Marburg outbreak that they've been having to see more Mpox cases being reported? Thank you.
Over to you, DG.
Thank you. I will respond to the first question. Dr. Ngashi will answer the second one. I think Shanelle will also talk about the vaccine allocation because we got also a question from BBC regarding that. The US election, let me be clear and loud. I'm an African leader. I'm an official from African Union. Africans, we are not voting for the US election. As we are expecting others to respect the outcome of election in Africa, we also will respect the outcome of election in the US. But we are saying we will continue to talk with the US government about a strategic engagement with Africa CDC and Africa in the health area. We are clearly saying, and I started to interact with some officials from the new president, and I'm saying I'm ready to fly anytime to the US to sit with them and to have dialogue based on what are key priorities in Africa. Because we believe it's time for us not to have a project approach for Africa. It's time for us to have a strategic and coordinated approach based on the plan that we have in Africa. Regarding Mpox, we got a clear commitment from the US president. He made it during the UN General Assembly. We are providing 1 million doses to Africa and $500 million to support the response. I will continue to engage President Donald Trump's administration for not only to fulfill this commitment, but also to increase the commitment of the US to Africa CDC and to Africa. I think my message is clear as we start to discuss with some of the officials, and you can quote me, we will continue to talk to them and to engage them to fulfill their commitment. Otherwise, if they don't do that, the mistrust that we have today in Africa will lead for a major issue between the US and the continent. It's time today to repair what was broken. And I know and I count to the US government to understand this message. And as I said, I'm available to fly and to meet and discuss with them about what Africa needs in the health area and how we can work together. Dr. Ngashi, about Burundi and the Rwanda issues.
Yes, thank you very much, DG. On the issue of Just to say that these things happened. We had already previous experience with Congo, Brazzaville. They spent 3 months with no cases, and suddenly they reported again 2 new cases. I think that happens when there is something that was missed during the surveillance system. But in the case of Rwanda, what we hear that it is a backlog of samples. Then when they then got the opportunity to test all those samples, then they ended up with the 20 cases and then went ahead to announce those 20 cases that have been identified. I think for us, moving forward as the IMST is to work now with Rwanda to understand what are the factors that contributed to the backlog so that in the future we can then prevent that from happening and have more real-time reporting of cases. On Burundi, DG, just to say that we have discussed with members of the Ministry of Health in Burundi. I think the discussions are quite advanced, I have to say so. There were a number of issues that needed to be addressed to clarify in the specific context of Burundi. And apparently, I think all those issues are being addressed now. We are hoping that in the coming weeks, we might get some positive feedback from Burundi to allow us to go ahead. But on the good news also on the other side is that when the allocation was made by you as the principals of the major agencies, yourself, Dr. Tedros, Gavi, and UNICEF, I think you had recommended that an allocation be made for Burundi, on condition that we receive the positive feedback from government that we are going ahead. I think just to say that all the pieces are coming together. We hope that in one of the coming weeks, we'll see some shots in the arms of the Burundi population as well. Over to you.
Africa CDC is not blacklisted. Burundi, Africa CDC, and all partners, we have allocation dedicated to Burundi. And as Dr. Ngashi said, we are hoping these vaccines to land there once everything is cleared. Then because we are talking about vaccines, I will hand over to my colleague Shanelle, who will talk about vaccine allocation, because we got also some questions from BBC and a number of journalists. Over to you, Shanelle.
Great, thank you. So I think as reported last week and prior weeks, there's been a donation of 5.7 million doses of vaccines. And we have visibility on availability for just under half of that. And so for the doses that will be available in November, an allocation was made last month, and that was reported last week on this press briefing. But at that point, we didn't give an itemized list of the allocations because we were informing the countries and also the donors. And so we wanted to share with you the specific allocations that were made to countries, which you can see on the screen here. Maybe just to note that these quantities do not meet any country's full needs. So this is a partial on the first allocation. Deliveries, in particular, urgent deliveries for DRC will be starting late this week, early next week. The next round of allocations for doses that will become available in December will occur this month. So we will have another tranche. Even those doses won't meet all of the country's needs. So as was mentioned by the DG a minute ago, there is urgent need for additional doses of vaccines. Maybe to say that you can see on this list that there are some straight allocations and then also some that have conditions. And you can see the comment on the right-hand side of what those conditions are. So for example, for DRC, there would be given additional allocation if they extended the use for children 12 to 17 years old. And you can see those explanations there. So we wanted to share this with you, also in response to the written question earlier from the BBC. And we hope within the next 2 weeks or so, we'll be able to give you an update on the next allocation round. Thank you.
Thank you, Margaret. Over, back to you.
Thank you very much. Let's take the next question from Janice of Bloomberg. You have the floor.
Good afternoon. Thank you again for the briefing. I just wanted to ask about a study that I saw last week. Dr. Blessed Mabala was one of the co-authors, and it was talking about the evolution of clade 1A. It looks like there's been some movement there, because some of the samples that they had looked at previously were as recent as August this year. And it seems like there'd been some mutation which was raising questions around whether this made clade 1A more transmissible in terms of human-to-human transmission and sustained human-to-human transmission. I was just wondering if you were, in discussions about this with the authors of that study, if you were aware of it, if you were seeing any changes on the ground specifically related to mutations in 1A.
Thank you. Let's take the next one. Kerry from Health Policy Watch, you have the floor.
Thank you, Margaret. I have two questions. One is related to the case fatality ratio in children, where the children are more susceptible to dying than adults. And then I just wanted to also follow up with Burundi. Earlier, it had been reported a few weeks back that all the Mpox cases of Burundi were being held in isolation in hospitals. I just wondered whether that was still the case. Thank you.
Thank you. Over to you, DG.
Sure. Dr. Ngashi was in Burundi a few days ago. You will also talk about the study, then I will provide more comment to complement. Over to you, Dr. Ngashi.
Yes, thank you very much, DG. The situation in Burundi is that the cases, I think one of the success stories of Burundi is the speed at which they get cases out of the homes to take them into the treatment centers. And we also have to say that these treatment centers receive quite good support and are very well organized. And the package of services that are provided is very holistic. You have clinical care, they are providing nutritional support with food supplementation to the patient, to the caregivers, even all the staff that are working in the treatment centers, and they are also supporting, providing psychosocial support. I think that's the situation. That's what explains the zero deaths that we still have in Burundi and also in the treatment centers, where we reviewed even some of the cases looking at pregnant women that had, after all, good deliveries after that, and children that were malnourished, that were also able to come out of the treatment centers, improved. That's the situation in Burundi. And then the case on the mutation of 1A, I think the first sort of the mutation is the 1B that we have now. So, as you know, that in those countries in Central Africa, it was the 1A that was a more zoonotic disease. Now that has mutated to become 1B. And then predominantly now human-to-human transmission that we see in Eastern DRC, and now also moving into some places like in Kinshasa, and the one that has also spilled over to the eastern part of Africa in Uganda, Rwanda, Burundi, and Kenya. But just also to say that even with the 1A itself, I think what has been observed, if you remember the case of country like Central African Republic, that there were also cases in Bangui, the capital city, that were predominantly also human-to-human transmission. That to say that in those contexts, we have seen both modes of transmission, one from animal to human, and then also from human to human, in the current outbreak. That's the reason why the DG had mentioned in one of the press conferences that in reality, we have multiple outbreaks within an outbreak. I think that is the situation about 1A. Over to you.
Yes, we have a number of studies ongoing, and we are discovering, if we can remember what I said in one of our press conferences, we have so many unknowns about Mpox. And every day we are discovering. The message that was going out was 1B, human-to-human transmission, and 1A, zoonotic transmission. That is not correct. And we know, and this is what is making us a little bit worried, because in places like Kinshasa, you have clade 1A and clade 1B. And with the mutation that is ongoing, because we need to accept that, we don't know what will be next. And we have also places where you have other clades together. I think this study, we show that, we commented on that. It's just what we are seeing every day on the ground, and we'll continue to conduct more studies to understand exactly the epidemiology of all of these Mpox outbreaks, because we have at least 4 outbreaks when we are talking about Mpox. Over to you, Margaret.
Thank you, DG. We have a question about the Bavarian Nordic Mpox vaccine in pregnant and breastfeeding women and infants in DRC. The question is about, they would want us to speak about the trial evaluating Bavarian Nordic Mpox vaccine in pregnant and breastfeeding women and infants in DRC. Over to you, DG.
Currently, we are led by recommendations from SAGE, the Strategic Advisor Group. And we are also led by what each country has put in place as mechanism to accept the use of a vaccine. As we said, like in DRC, NITAG, this advisory group is reviewing Bavarian for children. We cannot, if the clinical trials are not finalized, if we don't have recommendation from the SAGE, as Africa CDC, we cannot recommend the use of this vaccine if we don't have evidence. We need to know that we are a scientific organization. We are led by science and evidence. And for now, we have so many vaccines and medicines on clinical trials. We are not talking about it. We'll talk about it when we'll get the final figure. Over to you.
Thank you, DG. The next question is about the Africa CDC plans in building staff capacity and enhancing infrastructure upgrades to meet diagnostic needs in the global fight. How prepared are we to regionalize vaccine production and make it readily available as a preventative measure? DG?
Colleagues, our leaders were clear on the mandate given to Africa CDC. Local manufacturing is not negotiable. When we talk about local manufacturing, we talk about vaccine, we talk about medicines, we talk about diagnostics and other commodities. We are also tired in Africa. Every time we have an outbreak, we need to run to start to beg. If one day I will tell the story of Mpox, how we started to look for vaccines, and people, they were telling me the only quantity of vaccine available in the world is just 20,000 doses. And you can imagine we are talking about a continent of 1.4 billion people affected by an outbreak. And they are telling me that there is only 20,000 doses. And we started to engage people on a daily basis. We say the technology of Mpox vaccine is available. We already started the process for the tech transfer of technology to African manufacturers. We are working on that. This is the first one. The second one, about diagnostics. You will see when Europe and the US were affected, they managed quickly to put in place diagnostics for the clade 2. But today, we are struggling to put in place the mechanism for rapid diagnostic of clade 1B. We don't have. And what we are saying, when we are building our capacity, today in terms of diagnostics, we are decentralizing the lab capacity. We say during COVID, we didn't have capacity even at national level. Africa City supported almost all African countries, except those 3 or 4 who had, but almost all of them today, they have capacity to do genomic sequencing. Thanks to Africa CDC supported by Mastercard Foundation, we need to say that. But some countries like Nigeria, like DRC, like Ethiopia, they have populations in some cities that are more than other countries. Then we need to think how to be realistic on the way to respond, to decentralize. And this is what we are doing. Also, we are considering the challenge that we have in Africa. You know, transportation of samples is another issue. Then, by decentralizing, we are reducing this burden of transportation. Today, I can say we are in a good trajectory. You will see the statement that we are making that will be out, I think, this afternoon about a success story. Now, the PCR test kit we start to use in Africa will come from an African country, manufactured in Africa. When we are talking about local manufacture, this is our first success in Mpox. I make it, but you'll see the statement that will come because we are talking about a company manufacturing that in Morocco. 100% of specificity, 100% of sensibility. And that is a success story we are looking for. And Africa CDC will make sure to procure this testing kit to make it available to all African countries and to also support other manufacturers to do the same. I think with that example, we can say we are really moving, but we still have a long way to move forward for that agenda. Over to you.
Thank you, DG. The next question goes to Dr. Ngashi. Can you please explain, this is from Kerry from Health Policy Watch, about the case fatality rate in children. Are children more likely to die than adults? Over to you, Dr. Ngashi.
Yes, thank you very much, Director. That is true. I think there's an analysis of mortality that is ongoing right now. It is also expected. I think the finding that the mortality in children is 4 to 5 times higher for the younger children than in adults is something that we expected. But there will be a paper that will be published on our Mpox mortality analysis that will explain all that. The context is also something that you need to understand some of the contributing factors to the high mortality in children. As you know, these countries, especially in Central Africa, that we are talking about Burundi, DRC, there's also a combination of high malnutrition rate in those children. In Burundi, it's about 53% of children below 5 that are chronically malnourished. In DRC, it's about 42%. And if we look at the trend over the last years, it's a situation that has been there for over 5 years, not a plateau on the rate of malnutrition. That explains also the vulnerability of those children. And then the second element, also which might be contributing to that, is also the care-seeking behaviors. That for children that are already malnourished and so fragile, the more time you take to seek care, I think the more advanced the disease is and the poorer the outcome, at the end of it. We are hoping that at the end of this analysis, we'll present a fuller picture that explains exactly what's the situation and also how we can address that to really reduce the mortality among children. Over to you, Derek.
Yeah, in addition to what Dr. Ngashi said, we have also to know that co-infections are contributing. If you see in the eastern part of DRC, there is increase of measles. And that is another factor that is contributing, in addition to malnutrition, in addition to care-seeking behavior, in addition to the weaker human system from children. I think this study, as he said, will give us a more broader picture on what is going on. And it will also help us to understand why we have mortality in DRC, but in Burundi, where malnutrition is high, where there is also co-infection, till date, they didn't notify death due to Mpox. I think there are so many unknowns we want to understand that will help us in the future to address other outbreaks that we can have. Over to you.
Thank you, DG. And with that, we have come to the end of our briefing today. I'll just pass it on to you, DG, for your closing remarks.
Colleagues, dear members of the media, we declared public health emergency of continental security on the 13th of August. 13th of November will be 3 months since we are working on that. We have a continental response plan for 6 months. It means next week we are releasing the midterm report. And today we have the emergency consultative group meeting physically in Addis. While I'm talking to you, all of them are meeting in Africa CDC building. And on Saturday, the governing board of Africa CDC will meet to validate this report. This report will be available to you next week. And this report will talk about success that we achieved, challenges that we are facing, and will also share what we have in our dashboard. This is why we are saying to our partners, you still have a few days to provide information, because once this report is out, we don't want our partners to feel uncomfortable, because the figure that we have today of disbursement is not matching even 20% of the pledge that we got. We are also saying next week, we hope to give you more information about the success in Rwanda in terms of Marburg. And we are still working with the US government to lift the L3 status. I'm clear on that. The L3 status is not linked to end of the outbreak. The L3 status is linked to the possibility for the country to export or not the outbreak in the US. Now that we are out of election, let us start to talk science and let us lift this L3 status, because that one is killing the economy of Rwanda. As an African leader, I cannot accept that, because since we started to talk about Marburg in Rwanda, we didn't have evidence of transmission of any case out of Rwanda. We don't want to start to talk about political punishment. With that, we believe that next week, we'll share with you the report. We'll see more pledges becoming disbursement, and we'll see more action taken to support Rwanda to be out of Marburg. Have a good evening, good afternoon, where you are. Let us meet next week, next Thursday. Thank you.